office hours today. This is as close as I want to get to you. I don't know if I have anything contagious, but my wife had it, and she's fine now. But you know, it could be the way the wind blows. Sometimes the wind blows, you snort stuff up out of the air, and you just could be having similar allergies. I don't know, but I feel like a sinus infection coming on, or maybe it's the flu. But then I have a flu shot. Well, about flu shot.
Maybe you got it from the flu shot.
27% that you're over 65. Like right? So yeah, I think that the flu shots, they're supposed to keep old people alive. Those odds are not good.
Sometimes they make sick.
So anyhow,
I've never had it.
I'm going to skip office hours just so that I can be reasonably well to deliver a lecture on Friday as well. Because, goodness, we have lots to talk about on Friday, don't we? After Dr. Phil pontificates about our GAD, the SKY's GAD, the GAD, OCD, and specific phobia. Nice timing for our class, I think. So let's march on. I think that's what we were talking. I was talking a lot about that, wasn't I? This whole business of what do we add? What layer on this big onion do we add when we get this guy running around the country advocating for people to understand he is ill? It's a rock in a hard place, but I would argue this is not the best thing for him. So we're going to return to that momentarily because we want to look at those symptoms. I think I've already covered this slide. Panic attacks are abrupt, huge, intense. On a 100-point scale of anxiety, or 110. You're going to learn about them. You're going to learn how to respond to them. Actually, when your friends and relatives have one. There is something to consider about them, and we're going to have that covered today too, I hope. Anxiety is that same uncomfortable experience at less of a level. I've made distinctions on the previous slide from textbooks who say, well, it's more future-oriented than fear is. Fear is here and now. I'm telling you that if I had an elevator phobic with me and I put them on an elevator at that moment, it wouldn't be anticipating. It would be right here and now, intense anxiety, and they would get off of that elevator as fast as they could. So I don't like that distinction. Anxiety can be here and now. It can look like fear, and you're going to differentiate it. Who picked up on that? The single way in which you're going to differentiate fear from anxiety has to do with, anybody want to take a stab at that?
Irrationality.
Pardon?
How the fear is rational versus...
That's correct. And whether it is rational. Who makes that judgment? That's what they're going to pay you the big bucks for. If you go into the healthcare business, you're making judgments all the time. Referee calls, kind of. All right? So you decide if it's irrational. It's usually pretty easy, actually. I once was having a patient in Nashville referred to me for specific phobia. She was afraid of wasps. That's tricky business, isn't it? Wasps can hurt you, right? They all sting. It's not like, like snakes. There's good snakes and there's bad snakes, good wasps and bad wasps. They can hurt her bad. But if she's afraid of them to the extent that she stays in the house during the summer months when her family is in the backyard, she will not even join them in the backyard. In my judgment, that crosses the line between fear and anxiety. Because indeed, we all do that, and as you probably know, I don't think Texas has the same number of wasps that the Nashville area does. They don't bother anybody. They're not going to bite you unless you accidentally step on them. So with that that taken into consideration, by definition, it is irrational to be afraid and to go to those lengths then to avoid that particular phobic stimulus. Okay, so we'll return to that when we get to specific phobia. So this basketball guy then comes along at just the right time with all these anxiety disorders all at once. GAD is probably the base, the foundational disorder of this man. He's probably been an anxious kind of guy for a long time. And out of that anxiety that he experiences generally, you're going to see how this happens in a second here, highly specific, anxiety-motivated symptoms emerge beyond the GAD. He starts performing rituals to reduce anxiety, and now there are certain things that he sees that he won't engage in, like getting on an airplane, because that is also an anxiety-provoking situation. So in a package, he covers the anxiety disorders for the most part, all in one person. So with that having been said, to leave this slide behind us, there is genetic and familial vulnerability to both anxiety and panic. So, are you hearing a buzz like I'm hearing a buzz? Yeah. Let me just see if I can fix that, because I don't know what to do about that. Am I still on? Am I still on up there? I guess you'll have to tolerate it with me. There's a feedback thing for me too, so it's even more irritating down here. But here I am again, apologizing for the sound system. All right, so genetic familial, these are difficult things. These are just really difficult things to separate out. Moreover, if we have time, I'll go into more details with this. Genes have been way oversold. The idea that we play out our lives just by virtue of the genes we inherited and they just play themselves out until we're dead is a gross oversimplification of life. And, as I pointed out earlier in the course, from a genetic standpoint, never ask the question, is there a gene for OCD? Is there a gene for GAD? Is there a gene for specific phobia? There ain't a gene for any one thing with rare exceptions. There are multiple configurations of genes that interact with a favorable or unfavorable environment in a highly complex way that may energize behavior, but doesn't determine behavior. So, and then, it's really difficult. Your mother had anxiety and you're an anxious person too. Did you get her gene? Or is it familial as in you live with your mother? Do you think she didn't model that for you before you were even able to talk? You see how complex these things get? It's real difficult to separate these things out. And it's important for you to understand that as soon as we try to oversimplify it to talking about a gene for this and a gene for that, we've lost all explanatory power that we might otherwise have when we abandon the socio-cultural approach to understanding these very, very complex phenomena. Comorbidity in the anxiety disorders. Look what it says. This slide was made a long time ago. Anxiety disorders have frequent comorbidities. Most commonly major depression. I bet you somewhere along that interview with Dr. Phil, we're going to hear the word depression. But he's already proven to have comorbidities, hasn't he? He has GAD, OCD, and specific phobia. That's comorbidity. That's 3 mental disorders all in one person. That's what we mean by comorbidity. So anxious people And I'm defining these words for you. You know, morbidity is simply having an illness. That's a morbid condition. All right? If you die from it, that's a mortal condition. Okay? So we talked about morbidity and mortality. You will learn, I think I mentioned it once, and I'll mention it several times in this course, anorexia nervosa has the highest mortality rate of any mental disorder. So mortality is an important concept in understanding these mental disorders. But morbidity is as well, especially comorbidity. All right? Presence of one or more disorders in the same individual. Sometimes that comorbidity can straddle two different sets of disorders. When you have major depression being reported by someone with GAD, they are straddling two disorder groups, mood disorder and what we're looking at right now, anxiety disorder. Or they can simply straddle two or three disorders within a group, as our example is doing for us now. Was there a hand up here? Yes. For the highest mortality rate, anorexia nervosa. Yeah, a lot of people think, oh no, it's depression. It's the highest mortality rate. Maybe depression because you expect suicide, etc. Not even close. Anorexia nervosa has a mortality rate of 10%. That's enormous compared to, I mean, it's so far above and beyond any other mental disorder. It's like no contendere, no contest. That's a huge difference. We'll return to that. We'll return to that later. I think I may have mentioned in a different discussion. If I didn't, I'll probably repeat myself later. There was a recent mortality on this campus. A young psychology major who succumbed to anorexia nervosa right here. These things really happen. I mean, it's just for real stuff. Tragic when it happens, but nonetheless, keep in mind that it does happen. So, here we go, GAD. Very common, a very common anxiety disorder. Here's some facts, if you will, about this disorder. We used to call it anxiety neurosis. And when DSM-2 was around, it was the only thing. Remember DSM-2, that little thing that I brought in and compared to that fat DSM-4TR that I brought in? Remember that thing? So DSM-2, do you have anxiety? It was anxiety neurosis. And now they're getting a little more specific, and I like that because this GAD is a real phenomenon. You will see people who are just chronically anxious. Freud called it free-floating anxiety, always there. I like the notion of pervasive anxiety, always anxious. These people walk into your office, you can tell from the handshake, the posture, the gait, the look, the hygiene, the everything, including when they sit down, they're going to sit where? Right at the edge of the chair. Even though it's a recliner. I used to think, well, I mean, you can't find a more comfortable chair in the city. It's about as uncomfortable a place as you could. And it's because these people they carry tension with them everywhere. And yet, it's not a panic attack. It's not a panic disorder. It's not panic. They're rarely in a state of panic. They're usually at this lower level anxiety that is enough to say, I am so tired of it. I'm fatigued from it. And that becomes one of the symptoms you'll see in a minute. Probably around 4% prevalence. That means for every person diagnosed with schizophrenic disorder, there are 4 people diagnosed with GAD. Females have a market on this, about 2 to 1, much like depression, 2 to 1 ratio. Some of the oversimplified notions of genetics include, well, then it must be an X chromosome phenomenon, right? Because females have 2 of those, males have only 1. So the depression genes are connected to the X chromosome. And so are the GAD genes. Well, don't even waste your time with an explanation like that. It is way more complex, not the least of which is it is more likely for a woman to reveal to an authoritative figure like a doctor that they are experiencing anxiety, a vulnerable condition. Very difficult for men to do that. Very difficult for a man to walk in the door of a clinic and admit to things like depression and anxiety. And I think that accounts for most of the differential between the genders in the generalized anxiety disorder, literally all of the depressive disorders. There is, of course, another factor, and that is that women are socialized and culturated to be an independent role. And if you want to fast track to anxiety, panic, and ultimately depression, be in a dependent role. The more dependent you are as an adult, it's not a good fit for an adult, is it? The more dependent you are as an adult, the more likely you are to experience the discomfort of anxiety connected to all the things you can be anxious about with regard to taking care of yourself. So that too is yet another factor. And to the extent that we have these institutions called universities and women get equal education, to that extent the gap narrows as people develop more skills to deal with the vicissitudes of life, as I've always put it. A lot of these people are seen first by their primary care doctor. Because they have anxiety, they carry it around so much, they invariably have somatic symptoms, physical symptoms, often without an identifiable underlying physical etiology. If you're anxious all day, every day, and some of these people, by the way, can even prove they're anxious at night. How do they do that? You can hear them grinding their teeth at night because there's still muscle, facial tension going on in the life of the individual. They can literally be tense 24 hours a day. Sooner or later, what's going to happen? You're going to have pain problems, muscle-related pain problems, low back pain, headache, etc. So very frequently, these people become physically symptomatic, stemming from their psychological way of dealing with life. Like they have a lifelong course with long pre-treatment histories. They have learned anxiety so well, I like to say. It's an overlearned habit. And for the purposes of this course, at least as long as I'm the instructor, I want you to start thinking about that. Anxiety is a bad habit. Whoever thought of that, right? I didn't make it up, by the way. This is a behavior therapy a la Joseph Lopez idea. And it actually proves real productive in the clinic when you're trying to help someone change habits. If you look at anxiety, it's a bad habit like cigarette smoking. Maybe you can teach other things for that person to do than anxiety. And indeed, there happens to be a response that works perfectly to be, as I mentioned last time, incompatible with, reciprocally inhibitory of anxiety, and it is transcendental meditation. No, it isn't really. But I like to use that phrase because that sounds like something you pay for, right? Nobody wants to pay for relaxation. I mean, you can't sell that like you can transcendental meditation, although I strongly advocate TM for anybody who's interested in getting better control over their well-being and getting better control over their anxiety and depressive habits. I'm all for TM. But at the core of TM, as is the case for every altered state of consciousness that we use psychotherapeutically to help people live more effectively, at the core is fundamental, deep muscle relaxation. There are dozens now of manuals on how to achieve that. It is not something that you just decide to do 5 minutes every day. You, in fact, find yourself a manual. Progressive muscle relaxation, I think, leads the way An old book that's still good today is called You Must Relax by Edmund Jacobson, the originator of relaxation as a treatment strategy. It is something that you have to work at. And then once you learn it, you engage in it at times that are critical to you with regard to demands on your performance, or just in terms of your anticipation of uncomfortable events in the future as you think about them and as they stimulate anxiety. This is a response that is extraordinarily powerful on the parasympathetic side of the autonomic nervous system that competes with the fight or flight response, as I mentioned to you before. And I'm telling you, it is very, very powerful. So, again, I'm telling you something that actually takes some work. So if you got a GAD or an OCD or a specific phobia, it's going to take some work to get to the other side of that. The more you have, the longer it's going to take. Because this basketball player guy has a long history of some bad habits. And habits are very hard to break. It takes a lot of work. And that's why he's probably not taking medication right now. I told you about the medication I'm waiting for, didn't I? Did I tell you about the pill that I'm waiting for development of? Well, it's important that you know that. Because I am waiting so patiently for this. Unfortunately, I don't think I'm going to see it in my lifetime, but I'm waiting for the pill that I can take tonight. I didn't tell you this? And wake up tomorrow morning speaking Spanish. Every time I say that, people take it as a joke, and I recognize it is. But why is that any funnier than thinking about taking an antidepressant medication and now your husband's going to stop beating you? Now, I'm going to start saying your wife's going to stop beating you because wives do beat husbands too. But you see my point here? And why would you expect that one of these pills is going to overnight, or at least in a couple of weeks, institute a whole new set of coping skills that would normally take an enormous investment of time to learn? Yet when I say a pill that I can take and start speaking Spanish, you see the absurdity of the idea. Why? I can speak Spanish. However, I only know 3 words. I need a bigger vocabulary, and that's going to take work. A lot of work and a lot of practice. And I'm telling you, life coping skills are no different. They take a lot of work. But we have been enculturated medically, I think, across the board in America to believe that there are those kinds of simple solutions. And indeed, there are not. So, when you see someone with these symptoms, you are in it for the long haul. And the GAD person comes into your office, you've got a lot of work ahead of you, and the patient has even more. Because, first of all, you have to be able to help them find that 0 or near 0 level of anxiety. Because they're coming in at 20. You follow me on this 100-point scale idea? We're past 110. They're coming in at 20 because that's the way they walk around. And then there are times during the day they feel 50, 60. And that's their life. 24/7. So, both in that relationship have a lot of work to do to teach. Not only to teach relaxation, which is normally easy for someone who's not anxious all day, every day, but even more difficult for someone who indeed reports that level of anxiety that chronically. Okay? So, now, get to the matters that interest you the most. That question waiting to happen is GAD equals worry. If you're thinking of one word, what one word is going to remind you of GAD, it is worry. These people worry constantly. And they will wear you out with all the worries they will bring to your office. In fact, when they run out of things to worry about, They worry about not being able to worry about something. I'm not exaggerating. Like I should be. Do you ever have that sense in action? We all feel it sometimes, like things are going pretty well today. There must be something around the corner, right? That I can't anticipate and worry about in a direct, specific kind of way, but I know it's there, right? You've all had that experience. The GAD has that, not as an experience, but as a modus operandi. That is what they do. They are experts on anxiety. If you define expert as someone who can engage in it constantly. So they become a real challenge. We often in the clinic use whatever strategies are available to diffuse anxiety from worry. Because if you take anxiety out of worry, what do you got? Pretty empty motivational stuff, right? Well, I think about this, but it doesn't bother me at all. So why would you think about it constantly? You want to think about it constantly because it makes you anxious thinking about what it's going to be. So sometimes we use any strategy. A young lady years ago who came in talking about her two boys in preschool and kindergarten, worrying, as she had a laundry list, as you might guess. Textbook GAD, laundry list of worries. That day, it was nuclear warfare. And I may have mentioned to you this before. Sometimes humor. I'm always looking for any response I can get from the patient that is incompatible with the emotional state that's causing the problems. Humor is incompatible with anxiety. We often use it. Sometimes we get anxious and we'll laugh at it to kind of manage the anxiety. So I told her, I may have told the story before, but you might remember, I told her, because she was concerned that in the event of nuclear war, she didn't survive. She imagined her children eating out of garbage cans. And my response was, no, they won't be, because they will be vaporized, just like you. Who survives a nuclear attack in which one person isn't? And we laughed about that. We thought that was kind of fun. And her emotional state was different. It was like taking, and when you deal with GAD, the anxiety is like a block of cement. And at times you feel like you've got a chisel and a hammer. And you want to just bang at it, try to wedge something in, and then gradually poke away at it until you have a different emotional state. And we worked at length. And she had a good sense of humor. And that was used a lot. So you will see, in fact, in the literature, psychotherapy sometimes incorporates a brand of humor that almost makes fun of the symptoms. Another woman was obsessed with the idea that she would one day, thank God it wasn't now, I saw her probably 25 years ago, obsessed with the idea that one day she was going to go out and get in it. Go to McDonald's and just let them all have it at McDonald's. This woman was not big enough to pick up an Uzi, if that's what they're called. Is that machine gun thing? She's just this little bitty thing, and I just thought it was hilarious when she talked about that, and I laughed at her when she brought it up. So yeah, I think today I'm not sure I would have laughed. Okay, we got a whole different set of laws of behavior going on that I haven't been able to get my arms around, frankly. But in that day, that was a good bet on my part. There was no chance. This woman was neurotic as the day was long, and we used to even laugh about the levels of her neurosis and how irrational some of her anxieties were. To be apprehensive about doing something like that was laughable. So we laughed about it. And I do believe that indeed, let me put it this way, it contributed to the progress we made in therapy. There were a lot of other things going on that could have accounted for her level of anxiety. And we addressed those things in therapy as anyone would. I don't want to give you the impression that was the substance of therapy. it was an instance of employing, and here was where I was coming from in terms of my own training, and they won't be in anything that will reciprocally inhibit, countercondition, or you would prefer to know it as anything that is incompatible with the anxiety state that can be made to occur in the presence of anxiety will compete with that anxiety. And if you can get it above the level of the anxiety, eventually it will extinguish the anxiety response. It works. It works when you look at anxiety as a complex habit, as a complex behavior connected to identifiable circumstances in a person's life, much like depression is almost always connected to a whole host of things. Probably on the top of the list is disappointment and loss. And when you recognize that, you will see a person, I think, in a very different light than whether or not a specific neurotransmitter system is out of balance, for which, as I think I've already told you, there is absolutely zero evidence. I had a man in somebody else's office. I was interviewing this person for a set of circumstances that are irrelevant to the situation. He was a very interesting, very successful man. He was about my age. Actually went to high school, not the same high school, but we graduated in the same year. We connected on a lot of levels. He shared with me how his doctor, at one point in his life, put him on an antidepressant medication and said, your condition of depression is like diabetes. You have a biochemical imbalance, and this drug will restore the balance to that biochemical system that we call a neurotransmitter system. That doctor was very sincere, but terribly misinformed. How do you think he got misinformed? Who do you think was feeding him his science? The pharmaceutical representative, the drug dealer. A rose by any other name would smell as sweet. I named me. They are pharmaceutical representatives. They are well-trained people who absolutely know what they're doing, but they are not scientists. And that's what happens. Sometimes doctors get so busy, that's what they do. They have to. They take their information. They are informed through marketing rather than through science. And you know that already, that's my soapbox that I have been on and will be on until I draw my last breath, because there is no evidence of a biochemical imbalance except the biochemical imbalance that is created by the neurotransmitter-related drug. And that's why when the drug companies point to the fact that, well, take him off the drug and see if he's not depressed. Absolutely. No question. And that's why in that caveat on page 1 of your syllabus, I have you do not recommend to anybody getting off of these drugs because you might even kill them. Because they have created a biochemical imbalance that the body has adjusted to, and make no mistake about it, if they're taken off those drugs, they will have a serious withdrawal problem. Drug companies will tell you the disease is reemerging because the drug was controlling it. That's sweet marketing, but unfortunately, bad science. All right, so true for GAD as well. These people get put on benzodiazepines all the time. Have we talked about benzodiazepines at all? Xanax, Valium. You ever have one? They're great. Yeah, if you haven't had one, they're absolutely great. They work for 2 weeks. That's the science. And if you take them much beyond that, what are you risking? They are among the most addictive drugs in the world. And that's a fact. And there is no one that's going to argue with that in the medical or psychopharmacological or psychological professions. They are enormously addictive. And when you look at the science behind them, they are extraordinarily effective, and that's why they are, in fact, very appropriately prescribed for acute stress conditions. People going through more stress than any human should be able to tolerate. Perfect. They are excellent drugs to help someone who is overwhelmed. But when we think they're going to help someone live their life, that will only work if they only have 2 weeks left to live. Because that is indeed the psychopharmacology of that particular drug. That's the science behind those drugs. All right, so these people worry less if treated for about a couple of weeks. Do you see the point I'm making here about major changes have to be made in the way people live their lives, or it might be expected for them to be coping less effectively than the average person in our population, because of the lack of skills of dealing with the things that have been a part of their life. All right. They worry about too many things. I'm beating that to death because that's at the core. These people are worry warts. Is that phrase still one I've never heard of? Worry warts? They used to be around anyhow. That's somebody you can say that person's a worry wart. You got a picture of someone that's worrying all the time. They've got all kinds of worries. They go to bed worrying and wake up worrying. That's the essence of this disorder. Their worry escapes their control. Kind of like OCD. You know? These thoughts come into their mind. They think they've been contaminated, and they know that sooner or later, if they've been contaminated, something bad's going to happen, so they better wash their hands. And you ask them, come on, back in this chair is what you touched, and you're worried that that's going to, I realize it's irrational, but I get really anxious thinking about it. You see how anxiety becomes the motivator? I get real anxious thinking about it. How do I handle the anxiety? I wash my hands. Makes sense. That part makes sense. It's the threat that's irrational. And in fact, you might consider the OCD, at least the hand washing OCD, as a germ phobia. And indeed, they probably indeed are. And they probably have a great deal of difficulty, biology majors, dealing with, or maybe we shouldn't tell them, they're everywhere, including in our gut taking care of us, right? Those germs, yeah, they're all over the place. Can't avoid them. Fact. Sometimes the worry gets the healthier you are. Why? Because your immune system gets practiced. We talked about this earlier. Was it this class or my other class? We're talking about sanitizing hand sanitizers. How they've gotten so popular, and now the medical professionals are worried that we have too many people in society that are too clean, and we see now an increase in asthma and other related disorders that have to do with immune functioning that's been compromised by these sanitizing things. You sanitize everything. God forbid that you should run out of one of those things on a bad day because you have in fact compromised your own ability to fight with the germs. There's a similar, there's a borrowable idea there for psychological phenomena as well. Protect someone from stress, make sure they don't experience it. Doesn't it make sense? Why would they ever learn how to cope with it then? That works real well if you can continue to protect them right up to the last breath they draw. Of course, it's impossible. All right, so besides worry and anxiety, this is not big anxiety, sort of like a festering level of anxiety, smoke but no fire. They have other symptoms as listed here: restlessness, fatigue, concentration problems. When I just said those three, what might they be misdiagnosed as an adult?
ADHD.
ADHD. Thank you. Who said that? Me. Good one. Yeah, that's exactly what's going on now. We have adult ADD. I guess we're not ADHD anymore. They're ADD, simply. And that's that's a whole other thing. I think GAD is probably getting robbed a little bit by these folks who, in fact, are these restless people who can't stay focused on things, quickly bored, etc., and maybe irritable as a result. Muscle tension, sleep disturbance, mainly sleep onset disturbance. Have I talked about sleep onset insomnia? Okay, we'll wind down with that part of it then as we finish GAD symptoms. Sleep onset insomnia. Now, as I tell you this, probably in the last 10 years I have read more contradictions. So this is just one of these things I'm telling you out of my own training that has been useful for me, but it seems to be less and less true as time passes. So that's my caveat. But when you see sleep onset insomnia in a person with a given presentation, it's likely the rest that you're going to hear is related to anxiety. When you see sleep maintenance insomnia, the rest you're going to hear is probably depression. Now, just as soon as I say that, the first patient you see will contradict that. So it's not a black and white issue. What is this?
Oh, so it's possible then that someone can be misdiagnosed with ADHD when in fact they have GAD?
Yes. Well, I think, let me put it this way. In the absence of chronic worry, someone could be mistaken as ADD. With the restlessness being, if you will, a hangover of the H part of the ADHD when they were kids. So we'll return to that in more detail later because I think that's a bit of a hoax as well. Yet, to return to the sleep onset thing, by the way, how the sleep disorder professionals define that is the ability or inability to fall asleep within 30 minutes of going to bed. Needless to say, there's all kinds of criteria that you have to attach to it. It has to be relatively chronic. By the way, I do not recommend, if you're wondering if you have sleep onset insomnia, I do not recommend watching the clock to make sure that you fall asleep within 30 minutes. Obviously, that in itself will create an insomnia of a different sort. So, the patient will be reporting they always have trouble falling asleep, and it's typically well more than 30 minutes. They'll be turning the TV on and off, they'll be doing all kinds of things. You ask them, what do they think about? If it's GAD, what do you think they're going to tell you? I worry. I think about my worries. And I plan the next day. And I anticipate the problems I'm going to have the next day. And then I think, oh my God, if all of those things happen that I think could happen, I'll be overwhelmed. You see how worry goes? I mean, the person is just, it's self-inflicted punishment, or it's totally sound. But, much like OCD, it escapes the control of the patient. The patient says, I know I shouldn't be doing this, but I can't control it. And that is a very interesting neurotic tendency that we see in these anxiety disorders. Okay, so the anxiety and worry can come from a lot of different other places, and that's why when I talked to the news media about this basketball player, I said, you have to understand, we've been talking about him. I don't know who diagnosed GAD in this man. Maybe he diagnosed it himself by going on the internet. But anxiety can be a part of other things. It can be a part of something far more serious, like, for example, schizophrenia. So the mental health professional is often confronted with the really difficult task of making absolutely sure that what they're seeing is not a part of something else, but they're seeing, if you will, the wrong diagnosis as a result of a constricted look at the bigger picture. So that's where psychometric testing can be helpful. When you see GAD, you can do an MMPI, and I can tell you what that profile will look like. It's a 7-2. Remember how I said the configurations based on the numbers of the clinical scales? They look very, very similar. And that's where that MMPI is very useful. There are two other scales that get elevated at the same time, and the presentation appears to be GAD, you better do a couple more sessions to make sure you're ruling out a more serious manifestation of psychological dysfunction. Okay, I'll stop there, and once again, those who had come in late, know what we covered today. I will resume on Friday, God willing.
Hablé con ella ayer. Okay, so does anxiety... Oh no, don't worry about it.
All the zombies struggling with her
They're like... I think it's great. I really got like... Dude, I was something else.
too far out. But have plans.
I took it without like looking at it. I wanted to see how much I can learn. I guess it wasn't too bad, but I still wanted
I wanted to be higher that way. I can mess up on the last one.
right? You know, yes, actually.
Yeah.
Yeah, 12 o'clock. You're going to have to